And what kind of recommendations are there for, management of kind of the family members of patients who are found to have hereditary diffuse gastric cancer?
Yeah, that's a great question. So in 2001, David Huntsman published in the New England Journal the first report of a kindred that he identified with a germline CDH1 mutation where they underwent prophylactic gastrectomy. So there were 6 individuals that had their stomachs removed, and in each and every one of them, isolated foci of signet ring cell cancers were identified. So since that time, that's now been the standard, where individuals who are found to have a CDH1 mutation and are cancer-free, at least endoscopically and radiographically, the recommendation is to proceed with a prophylactic gastrectomy, typically in their 20s. The risk of developing gastric cancer is about 1% per year, and the penetrance is 60 to 80% over the course of a lifetime. So if patients are in their 40s and 50s, they have a moderately high risk of developing gastric cancer shortly after that.
Okay. What about any other cancers that, they're at risk for developing?
Right, you're right. Thank you for that. So CDH1 loss or mutations are also associated with lobular breast cancer at a higher risk, as well as signet ring cell colon cancer. At this time, there aren't differences in screening for lobular breast cancer, but it's something that physicians and clinicians need to be aware of.
Okay. We'll move on to the next question here. This is about postoperative versus intraoperative radiation therapy. Is there any evidence for a survival benefit or difference in survival benefit between postoperative or intraoperative radiation therapy in patients with resected gastric cancer?
Good question. I think intraoperative radiation is emerging. And so we don't have certainly any randomized studies that compare the two. The advantage that you can deliver a high dose of radiation over a very short time and limit toxicity. To date, most of the data that we know for intraoperative radiation is to help clear a margin. Or that kind of thing. But as a routine for gastric cancer where the tumor is resected, the margins are clear, the standard therapy would still be postoperative chemoradiation as per the McDonald study.
Okay. What about intraperitoneal chemotherapy?
Yeah, intraperitoneal therapy is also under investigation. So this comes from the high risk of peritoneal disease that patients with gastric cancer have. So again, 30% or so of patients will present with peritoneal disease, and over the course of their lifetime, maybe 50% of patients will develop peritoneal disease with gastric cancer. There are studies looking at novel targets for peritoneal therapy, and there are some surgeons who are able to resect the omentum and do a peritonectomy and introduce heated chemotherapy into the peritoneum, something called HIPEC. That's really more of a standard approach for colon cancer or especially the low-grade mucinous tumors of the appendix. For gastric cancer, I think it's still something under investigation, but it does potentially offer a therapeutic advantage because you can deliver high doses of treatment within the peritoneal cavity where the tumors reside.
Okay. Have you had any patients who've had, a very remarkable response to therapy that you would consider them cured or close to cured, or, who initially had metastatic disease or stage 4 disease that ultimately were able to undergo surgery?
Yeah, so these patients exist where we have really dramatic responses to treatment and they're durable responses. That actually brings up lots of points. I mean, how patients cope with cancer is important, and people really hear and see the median number, but they don't see the tail on the curve. So there is a percentage of patients, a low percent, that actually have long-term survival without requiring surgery. I have them in my practice, and many of my colleagues have them in their practices. If we knew how to get there for everybody, we would do the same thing. I think characteristics of these patients are that they have a very dramatic response to first-line therapy, and it's durable. Many of my colleagues use maintenance treatment as a strategy to try to control dormant disease, but ultimately we don't understand these outliers, and I think that's an important aspect of perhaps the future studies, perhaps sequencing these outliers to identify ultrasensitive patients who might have a better outcome. The other thing that I want to mention is that we are also seeing, especially with more trastuzumab use, patients with long-term use presenting with new brain metastases, and that was a phenomenon that we saw in breast cancer as well, where the brain is a sanctuary site and tumors can get there and patients can recur, and so we're beginning to see that as well.
Is there any way to predict kind of which, patients who have HER2 positive tumors, are there some patients who, respond better than others, and is there any way to predict that?
Right now there isn't. I mean, apart from HER2 testing, and of course the high IHC positive patients, IHC 3+, or the IHC 2+ FISH positive patients, these are the ones that probably have the most benefit from trastuzumab therapy. It's really an exciting time for HER2 targeting, though, because we're really leaning on the advances in breast cancer, where pertuzumab has demonstrated remarkable efficacy as well as TDM1. These are actually studies that are now being performed in gastric cancer, HER2 positive gastric cancer, both in the first-line setting as well as in the second-line setting. Actually, another thing I wanted to mention is that trastuzumab, the dosing of trastuzumab was, at least in the TOGA study, was borrowed from breast cancer dosing. So it was an 8 milligram per kilogram load, followed by 6 milligram per kilogram maintenance therapy every 3 weeks. And what we found is that about a third of patients are actually underdosed with trastuzumab, at least gastric cancer patients. We think that's because of the bulk of the disease, with the primary tumor in place, often with visceral metastases. So there's an ongoing study looking at high dose versus low dose trastuzumab in the first-line setting as well. So I think we're learning more and more that although these targets are important, we need to know the specific disease context as well.
Okay. A couple more questions from the audience here. This is a question about the AKT pathway. The AKT pathway has been well studied in patients with colon cancer. Any comments on this? Has it been studied in gastric cancer?
Yeah, it's an active area of investigation. I know of at least one drug company that's moving into a second-line study with an AKT inhibitor, and others as well. So, there was actually a phase 3 study of everolimus, which is, the mTOR inhibitor, which is downstream of AKT, and that was a negative study. But, there wasn't any patient selection in that. So I think if we, are able to target the AKT pathway, specifically in tumors that are have that pathway activated, I think that there's hope for benefit there as well.
Great. Next question. Overall, while the targeted agents were initially hailed as the paradigm with a lot of promise, it appears that either we are not there yet or they are not the big promise that they were initially meant to be. Kind of, what do you think the next steps are for kind of going forward in kind of the development of clinically useful targeted agents in gastric cancer?
Yeah, so I understand the pessimism in that question. I think that, with the emergence of targeted therapy, there was a lot of hope that we would have another Gleevec for just tumors, where you could just give them Gleevec and people would have disease control for years. But upper GI cancers, as well as other solid tumors, are complex tumors, and there's probably more than one driver, and the genetic background is very complex. So I think that we will get there eventually, where the right combination of targets for the right patient will achieve incredible success. But we're not there yet, and I think that we need to put more patients on trials, get more tissue samples, and do more with molecular annotation. I think with time we'll get there.
Okay.